All right, well, welcome back, everyone. We have our series of two additional keynotes to move on to. And so I'm very excited to welcome our second keynote speaker, Dr. Elizabeth Krans. Dr. Krans is an assistant professor of obstetrics, gynecology, and reproductive medicine at the University of Pittsburgh. She is board certified in obstetrics and gynecology and addiction medicine and serves as the director of the Pregnancy and Women's Recovery Center at Magee Women's Hospital, where she's been providing clinical care for pregnant and postpartum women with substance use disorders for over 10 years. Following residency, she received training in health services research with the Robert Wood Johnson Clinical Scholars Program and runs an NIH-funded research program focused on improving healthcare delivery processes for women with substance use disorder. She is an addiction medicine expert for ACOG and has served on various state and federal task forces focused on improving clinical care approaches for women with substance use disorder. Thank you so much, Dr. Krans, for your time and your expertise.
Thank you guys so much. I'm so excited to be here and meet all of you, even if it's virtually. And I'm thrilled to be part of your initiatives and want to help in any way that I can with some of our experiences that we've had in Pittsburgh. Should I share my screen, Susan, just for the present? How should I do my presentation?
That is up to you. If you'd like to share your screen, that's just fine. We also have your slides from our end as well, whatever is most efficient for you.
Yeah, if y'all want to pop them up, we could do that too. If that's quicker, that's cool. And then do I just say next slide or whatever?
Yeah, that would be fine. Cassie, Perfect. Would you be able to share the slide deck?
Yes, Jillian, if you have it handy and ready to go, feel free. Yeah. And if not, I can jump it. Thanks.
I will get it up momentarily.
Thanks so much.
Thanks, guys. Yeah, I'm super down with the yoga breaks. I thought that was great. It's a great way to decompress between a lot of virtual presentations. I thought that was awesome. Thank y'all so much.
I think we just have to, oh, perfect, there it is.
Awesome. And whatever format works best, I enjoy collaborative discussions. So if you guys want to interrupt or raise hands, somebody please help me if there's chat questions, or we can save to the end, whatever works best for the format for the group. But I'll go ahead and get started because I probably have too many slides. I just want to share some of the things that we've been working on and look forward to everyone's comments. So next slide, please. So I literally kept myself to two slides about the epidemiology because everybody is aware of that. This is just some of the most recent data showing the rise in substance-exposed newborns, as well as maternal opioid use disorder diagnoses over the past approximately 10 to 15 years. This is some national data from my colleague, Stephen Patrick. Next slide, please. And this is some data from our research group. As we know, substance use is a contributor to both pregnancy-associated morbidity and mortality, as well as severe maternal morbidity. This is work that looks at the contribution of different categories of substances to severe maternal morbidity. And this is also stratified by age. So looking at cannabis use, which does not have a significant association, but when you get to opioids and stimulant use disorders, we often don't emphasize the rise of stimulant use across the country and its contributor to co-occurring substance use or polysubstance use among many of our patients, but it is a significant issue and we struggle with that as well. So looking here both at opioid use disorder as well as stimulant use disorders and their contribution to maternal death in the United States, incredibly significant. Next slide, please. So as was mentioned, I think in some of the earlier discussions, this is in the hospital setting, this is really a patient safety issue. It's a social issue. It's a US issue. It's an ethical issue. It's a human issue, but like I said, we need to remember it's also a patient safety issue. So we need to inform our clinical programming so that it's evidence-based because many deaths are highly preventable and we can save women's lives by simply employing evidence-based interventions. Next slide, please. So I do want to speak a little bit about evidence-based practice. That's a term that's kind of thrown around a lot, but we really need to make the transition to performing our clinical responsibilities and duties in a way that is evidence-based and ethically and socially responsible. So the point about evidence-based practice is to really develop and promote an explicit and rational process for clinical decision-making. So a stepwise approach to clinical care that uses the best available evidence. And this really de-emphasizes historically the way medicine really was largely practiced for many, many years, which was based on just intuition and just thinking that something is right. And then really, in contrast, emphasizing incorporating research findings and again, the best available evidence into how we conduct ourselves on a daily basis with patients. Clearly, there's a variety of barriers. This is simple to say and hard to do. There is a lot of money, as we know, invested to support the development of a lot of interventions, but very few are implemented in clinical practice. I think that's my biggest frustration why I'm a health services researcher is because it drives me crazy to see lots of great research and then to see clinical practice that is completely inconsistent with that great research. So closing that gap is an objective of mine, and I know a lot of individuals working at this issue. So interventions, even when they're incorporated, it often takes a lot of time for that process to happen. And then disciplinary silos. So I think there's evidence-based approaches in nursing, there's evidence-based approaching in medicine, in the social sciences, in behavioral health care, and often those approaches don't coexist or cross disciplinary domains so that you have lots of parallel processes going on and you don't have true integration. And I can't think of another medical disorder that is more interdisciplinary than substance use. It involves every team player and care provider that there is. So crossing those silos is key to providing actual evidence-based approach to the care for this population. Next slide, please. So here's kind of the three interacting circles that create theoretically an evidence-based approach. So incorporating again the best research evidence, some clinical experience from the providers. So caring for this particular population does matter. And then absolutely, and probably most importantly, patient values and preferences. So we have to make sure that our discussions and our interventions are designed with patient values and preferences in mind at all times. Next slide, please. So I think it was mentioned earlier about AIM. I was fortunate to be able to be on the AIM work group for the development of the substance use disorder bundle. This bundle we just finished the revision. So this has been now revised. And I think there's a webinar coming up at the end of this month or the 25th of October to go over the revised bundle. This was from the original bundle, and all of the AIM patient safety bundles are being revised in really positive ways. But they serve as a resource for perinatal quality collaboratives and state level initiatives, system level initiatives, to have a place to go where what we try to do is really synthesize all of the existing evidence. There wasn't any new information. It was more of a synthesis of existing information so that hospital systems, quality collaboratives could go to one source and find examples of clinical pathways and approaches that incorporate best practices into the development of those pathways. There was also development of metrics, because whenever you implement an intervention, we want to make sure that it's working and then that there's fidelity and it keeps on being used. So metrics to monitor the adoption of EVP practices and ensure consistency in clinical care needs to be part of any initiative to improve clinical approaches. Next slide, please. So this is just an example of some of the categories that AIM uses to really break down the approach to the different chronic issues, this being opioid use disorder, and in the revision it will be substance use disorders with an emphasis on opiate use, but for the larger substance using population. So readiness, recognition, prevention, response, there's also reporting and systems learning. And then the fifth component, which is new for all of the revised bundles, is respectful care. So that's a new addition to the AIM framework, which I think really takes it to the next level of incorporating patient values and preferences into clinical care. Next slide, please. So I'm going to go over a few because I think it's helpful to look at examples, because I think it's easy to talk about the literature, but I'm going to, after talking a little bit about some of the literature, I do want to talk about some of our just personal experiences here at the University of Pittsburgh of how we have tried to incorporate evidence-based practice approaches into our clinical pathways, because I think we really need to start taking that next step of, okay, what are we doing on a daily basis? How are we changing it? And what are some of the barriers or issues that we've faced? Not saying that it's perfect or the best absolute way, but I just think an example is helpful when talking to other systems and care providers. So I'm going to go some examples of our initiative with substance use screening, initiatives related to medications for opioid use disorder, sexual and reproductive health, hepatitis C, and then some emerging topics at the end related to stigma and COVID-19. Next slide, please. So substance use screening, incredibly important. It's always important to start with screening, because if you don't know what's happening, then you can't do anything. So screening should be universal. So all patients walking through the doors of any inpatient outpatient setting should be screened for both licit and illicit substance use. And screening means a conversation. That's a communication between patients and their providers. And that typically is how fostered with a validated tool. So here are the 6 tools that have been evaluated in pregnancy. Most of them are indirect screeners. Some have indirect in their name, like the Wayne Indirect Drug Use Screener. Which when I say indirect, they're really asking about co-occurring factors that are associated with an individual substance use. And then there's the NIDA Quick Screen, which is a direct screener. So that asks direct questions about the actual individual's use of drugs, alcohol, and tobacco. So screening, aka a conversation, should be universal, and selective screening based on quote unquote risk factors or a provider's thoughts or preferences perpetuates discrimination and will miss women with substance use and is unacceptable. Next slide, please. So here's a recent, there's been a couple recent papers on this, which I thought were really thoughtful that I wanted to bring up. So this is a paper looking in AJOG MFM that looked at PRAMS, which is a national data set that looks at patients' responses to questions about their care experiences during pregnancy. So this was looking at the question, during any of your prenatal care visits, did a physician, nurse, or other healthcare worker ask you about cigarettes, alcohol, or drugs? So this was the patient's response to being asked if they were asked this question. So the vast majority of individuals did report that they were asked about cigarette or alcohol use, but a smaller percentage reported that they were asked about drug use. And I think most interestingly, individual level factors associated with an increased odds of reporting substance use screening was skewed by educational status, marital status, race, and insurance. And that's incredibly problematic because, again, this should be universal. This should not be selective because that promotes bias and really perpetuates stigma that we want to avoid. So I thought this was thoughtful for those findings. Next slide, please. So moving from screening and conversation and how that should be a conversation with all women to testing, which in most situations involves urine or UDSs, urine toxicology, other terms used for that. And that should not be used universally or as a screening for substance use in any population, and this particularly pregnant population. There's 1,000 reasons that UDSs are really awful. I use them all the time in our treatment setting, and they're very frustrating. So they have a very short detection window, and that is substance dependent. So there's all kinds of false negatives associated with when the particular individual used a substance and whether it can be detected on a urine screen. And for the same reasons, it doesn't capture binge or intermittent use. It has nothing to do with alcohol. And then there's a variety of synthetic opioids that most kind of common screening urine drug screens do not detect. So you have false negatives when somebody is using exclusively fentanyl or carfentanil or another synthetic opioid. And that's a struggle that we have because we still do not have a screening assay for fentanyl in our system. And that's the majority of opiates that are being used right now. So basically specific criteria for when a urine drug screen needs to be established. So that needs to be articulated up front. in order to avoid profiling or discrimination, because there are clearly serious consequences to having a positive urine drug screen, just both from a child protective services perspective and from a privacy perspective. So consent and patient awareness is absolutely necessary to obtain. Next slide, please. So this is great because I think I want to show you our personal clinical pathway. And this literature kind of helps with some of the decision making that we came to. Again, this is just our personal experience, but this paper was another AJOG MFM paper that looked at the relationship between an indication for a UDS and the UDS results. So this is in a system where they looked at indirect indications for testing. So these would be like preterm labor, abruption, things that substance use can cause, but not direct substance use related issues. So hypertension, complications of pregnancy. And then there was a direct indication for ordering UDS that was reported substance use. So the prevalence of UDS screening in this, or UDS testing in this population was 2.7%. And the only indication associated with a positive UDS was current or prior substance use or direct. So all of the kind of indirect, historically correlated indications with substance use were not associated with having a positive UDS. And Black and Hispanic women were more likely to have a UDS for an indication other than reported substance use or the acknowledgement of substance use. So here you see indications of potential profile and discrimination. And then, as you guys will know, in Colorado, the majority of the UDSs were positive only for marijuana, as marijuana is the most common substance used, and depending on the state, whether it's illicit or illicit. So here really just, this begs the conversation of, do we need to look at these indirect correlates as a criteria for UDS screening? Next slide, please. So going a little bit through our process, we wanted, because we were using some indirect correlates for ordering a urine drug screen, and we wanted to move away from that process, as this is really the first literature to kind of substantiate that, that direction. So we wanted to change our approach, and the first way to change that approach is to provide universal prenatal education. So let patients know that you're going to be asked about substance use during your pregnancy. So let's just put it out there, and everyone's going to be asked about this. It's just part of our standard of care. And so it's not a surprise for patients when a provider has a conversation. And that decreases the stress of the provider to feel like they're going to be the first one to talk to patients about substance use. So that was one step. Next slide, please. And the next step was for the universal screening. So prenatally, we actually embedded direct questions about substance use, so analogous to the NIDA quick screen, so directly asking for the use of alcohol, tobacco, or drugs. And then we also, we also wanted to ask, we did the PHQ-2, we wanted to ask about depression, we wanted to ask about social support and intimate partner violence. So those were things we also found valuable to make sure that all women were asked during pregnancy. Next slide, please. And then we created a clinical algorithm. So, you know, this is not meant to be really read in detail. It's meant to just show you that we wanted to really represent each decision step in the process, from the clinician administering the screener, what the different responses could be, what the provider should do with each of those responses, and then what ultimately, after the universal verbal conversation screener, what led to the actual ordering of a UDS. So next click, please. So the first part is really trying to outline that decision to obtain a UDS. Next slide, please. And then what happens when a UDS results and how we inform the patient of that. So first obtaining, so prenatally, we obtain verbal consent for the UDS, which is documented. And then we also describe what we do with those results to the patient. Next slide, please. Because that is part of our algorithm for informing who would receive a UDS at the time of delivery, and making patients aware that if substance use is identified at the beginning of pregnancy, there will be a reevaluation of substance use at the time of delivery. Next slide, please. So this is an example of an epic dot phrase that we use to help providers with documentation and to decide to help guide the conversation that they're having with patients when ordering a urine drug screen, to make sure that patients are informed and providers feel like they have had an appropriate conversation with patients. Next slide, please. All right, so let's skip to delivery. So prenatally, universal conversation in a select group of individuals who had reported substance use. We would do a urine drug screen, and then next is delivery. So at delivery, everyone is re-screened with the NIDA-Quick screen. So again, everyone who comes through our labor and delivery unit receives, and here's an EMR integration of the NIDA-Quick screen. Everyone is asked again and again. Everyone is provided with education that these conversations will occur. Next slide, please. And then here's our inpatient flow. And again, not to kind of go into the nitty gritty of the flow chart, but we have a flow that makes it objective and takes it away from individual decision making, so that providers can refer to the flow and everyone feels comfortable on when to obtain a UDS at the time of delivery. And again, we removed any kind of corollary reasons to receive a UDS. It's really if there was a report by the patient of substance use, we do UDS. If they were engaged in treatment, we would do UDS, or if they were prescribed a substance, et cetera. So direct reasons for ordering a urine drug screen. And then last click here, just what we would do if those results are positive, and then ensuring the accuracy of results. So in our initial screening, there may be false positives or false negatives. And if that occurs, ordering comprehensive screens to make sure that the results, if they are needing to be reported to social services, are accurate and not a false result. Next slide, please. And then at delivery, we actually created a permission form. So this is a written, it's not a consent for a variety of legal reasons, but it's a written acknowledgement or permission to allow us to send a UDS for patients. So it should never be a surprise. And then there's the reasons outlined here for a patient to have a UDS. That should never be a surprise. It should never happen without patient acknowledgement that is going to occur. So 2 layers there: prenatal layer of screening and evaluation, and delivery. Next slide, please. So that's our overview of kind of how we approached incorporating a revised substance use screening that really was built on just direct correlates of substance use, universal conversation, and then a direct algorithm for when and how, and the importance of consent to be obtained prior to UDS screening or UDS testing. I want to switch gears a little bit to talk about MOUD. Next slide, please. So MOUD, which in pregnancy is most often buprenorphine or methadone, is where it's at. You got to use it. I mean, there's just really no alternative. I can't emphasize the importance of MOUD. This is my favorite slide because it has that nice decline in the red line, which is overdoses with the increase in the use of buprenorphine and methadone. This is data out of Baltimore. Next slide, please. And this is treatment retention rates. I think it's always helpful to go back to treatment retention. And the highest rates of treatment retention are with methadone, period. Next is buprenorphine products. Behind that is naltrexone or antagonists. And then abstinence and detoxification, I would argue, are lower than what's presented in the pregnant population, but they're at the bottom and not effective. So I think it's always helpful to look at these rates and to understand the importance of medication for OUD treatment. Next slide, please. This is some work that we just recently published in Addiction. So we know that MOUD decreases overdose. That's true for pregnant and non-pregnant populations, but we wanted to look specifically at some perinatal outcomes because that really hadn't been looked at closely between women who had OUD and were not on medications for opioid use disorder, such as methadone or buprenorphine. So we looked at the effect of the duration of MOUD on overdose, preterm birth, term low birth weight, neonatal abstinence syndrome, and postpartum MOUD continuation, or basically continuation in treatment. Next slide, please. So here's the maternal outcome. So looking at overdose. So as the weeks of MOUD increased, so the longer an individual was on MOUD, You see a decline in their odds of overdose there on the left-hand side. And on the right-hand side, you see if you can engage an individual in treatment during pregnancy, you see that immediately jump up their odds of staying on treatment after delivery, which, as we know from prior data that was presented, the risk of overdose in the postpartum period is significant. If you can get that engagement in pregnancy, their likelihood of continuing after delivery is much more significant. So significant improvement in maternal outcomes. Next slide, please. So here you see rates of preterm birth decline. We did not, the decline in term low birth rate, look at those confidence, it was not significant, but we did see an overall trend. But preterm birth did make a significance. That's less than 37 weeks time of delivery. And then there's NAS. So similar to MOUD continuation postpartum, it was almost like a selection bias. You see this spike, but then it didn't continue to increase. It was basically the presence or absence of NOWS, or neonatal abstinence syndrome. So there may be a little bit of a selection bias in that process, in the sense that women who are in treatment their infants may be more likely to be observed for NAS than individuals who may not have disclosed their use disorder, or it may not be identified during their pregnancy. Next slide, please. So this is an initiative that we started because MOUD is super important. And we have an outpatient treatment program, which I run and we love and is great, but connecting patients who are not in treatment to outpatient treatment programs is easier said than done. So just hoping that they will appear in treatment programs is totally not acceptable. And what we were finding at our healthcare institution is a lot of women were presenting to the emergency department in withdrawal because they had nowhere to go, and they were in withdrawal and they couldn't find care. So how do we close that gap between women who are presenting to these non-traditional locations like the emergency department, and how do we link them to care? So next slide, please. So we created, I see a couple chat questions going on. I'll get to those in just a second. I'm so sorry. We created basically a kind of mini ED consult situation. So prior to 2017, when we initiated this, we are in the large women's hospital and we have an ED attached to the women's hospital. So a lot of people coming into that ED are pregnant. But the ED providers, none of them were waivered to provide buprenorphine. They felt very uncomfortable with the process of initiation of MOUD during pregnancy. And the only option at that time was, the immediate option was, okay, I could admit you for methadone, or I could just send you home to follow up at some random treatment program for buprenorphine. But there was no administering of any interim MOUD, interim buprenorphine. And the patient was essentially sent home to use for a little while if she wanted buprenorphine until she could get an intake and an outpatient treatment program. So that's clearly totally unacceptable. So we basically, myself and a couple of nurses, so I just want to be also super clear that, you know, some of this education and peer-to-peer guidance can be provided by a wide variety of care providers. So nursing, peer navigators, APPs. It doesn't have to be physicians at all, because our clinic is largely nurse run, and they're the best addiction medicine providers in the hospital that we have. So I just want, when thinking about creatively about ways to provide peer-to-peer support, it can be through a variety of disciplines. So anyway, what we did is we just said, okay, we're going to be available by phone 24 hours a day, 7 days a week, so that when somebody comes in the ED, they just give us a call, and it's a phone call. We don't go in, but we just talk through the situation with the ED provider and help them triage the right way to manage the patient. And if the patient needs to be dosed, if they're in withdrawal with buprenorphine, we're going to help them with how to dose, the type of dose, so they feel more comfortable. And then we created another clinical pathway flow diagram for how ED providers should contact us. Next slide, please. So, and we made it super easy. You know, here's just some of our language and verbiage. We went on MedTrack and put our name into PetTrack and just made it easy to give us a call. And, you know, in no time, we we were receiving a lot of calls from the ED, and we were really closing that gap for patients who presented in withdrawal. And we had a great partnership with the ED to get all of their providers waivered and to really start to feel comfortable with caring for this particular population. Next slide, please. So this is our clinical flow that we created for the ED that involved giving us a call and evaluating for which particular pharmacotherapy the patient might be interested in and how to administer that particular pharmacotherapy. Next slide, please. So key to this, which is like my favorite part of the whole thing, is the buprenorphine to-go pack. So like if a patient presents on like Friday night, you know, most outpatient treatment facilities, including ours, are only open Monday through Friday. So what we did is we created this to-go pack of 5 8 milligram films, which would get most patients through the weekend, so that they were not without meds before a treatment intake on Monday or Tuesday. So basically, it was an inpatient order, and pharmacy allowed us to put these little to-go backs in the AccuDose in our ED. So that, and since it was an outpatient dispense, the provider had to be waivered. So that was part of the initiative to get all the ED providers waivered. But basically the patient could leave the ED. So they didn't have to go to the CVS or the Rite Aid, because again, it's too much to ask a patient when they're in withdrawal and struggling with their recovery to go to a pharmacy, in my opinion. So to allow them to be dosed in the ED through the inpatient mechanism, and then to leave the ED with a small script for that medication that would bridge them to that next outpatient treatment appointment, was a really key component of this whole ED initiative that really kind of eliminated the gaps in care that our patients were experiencing, not being able to be immediately engaged in treatment. Next slide, please. So we saw a big jump in buprenorphine initiation in the ED, both of just administration to patients while they were in withdrawal, so directly dispensed in the ED, as well as going home with this to-go pack. And this is broken down by quarter. So basically we kind of, by quarter, we do like 4 or 5 dose packs, maybe 1 dose pack a week. And then by quarter up to, 20 patients. I guess that's a 4-month period of time, are dosed in the ED every three months, which was a significant improvement. Next slide, please. So that kind of ED relationship was awesome and really took off. So then we expanded it. so that basically, not just the ED, any inpatient or outpatient setting could give us a call. And so the point is not to have every health system create a consult service. The point, because that's not feasible for all clinical settings, but the point is to have some kind of point person that people can contact and get in touch with, who feels comfortable enough with how to at least initiate medication, and to guide another provider through the process, I do think is key for every clinical setting. So it doesn't have to be any kind of fancy formalized thing, but to have a one point person, like I said, it could be a peer navigator, it could be a nurse, it could be a social worker that is the point person or the clinical champion or the individual who's going to be the sounding board for the vast majority of clinicians who just don't feel comfortable caring for this particular population, which clearly all of us are working to change, but it currently exists. So being able to have that person that a variety of providers can reach out to, I do think is important for all clinical settings. Next slide, please. And so, in our particular version, we get consulted all the time now. We get consulted constantly. And I do, my only concern, which we're thrilled with our program, my only concern I think was related to that recent chat. Now I will get to the chat questions, I promise, is the more formal you get, you don't want to be a crutch for providers not to have their own knowledge and understanding enough of the situation to be able to clinically manage the individual. So one danger of our approach is taking away providers need to themselves be able to clinically manage individuals. So that's a tension that we are dealing with, and making sure that not only are we helping with the answer, we're helping providers know how to get to the answer on their own, and we are simply available if they have further questions, because we do want all providers to feel comfortable and theoretically be able to care for most individuals without support. Next slide, please. And then quick shout out to naloxone. Everybody should get naloxone. It should be in the water and next to the gum when you go out in the grocery store. It should be everywhere. So in our ED, we have an alert that any of these chief complaints that are entered into the system, a naloxone alert fires. And we're working on getting this in our labor and delivery AccuDoses. Everybody goes home with this, as well as our inpatient and postpartum units. So there should be like 5 extra naloxones, floating around in people's homes, just in case, you never know. So this should, we cannot overprescribe naloxone. Next slide, please. All right, I'm gonna wrap up MUD. It's my favorite topic, but this is just some data it's a little bit older now, but this is looking at who is prescribing buprenorphine for pregnant women in Pennsylvania Medicaid. And next click there. So if you look, OBGYN is real small on the type of providers that are providing buprenorphine for pregnant women. So the most of providers are primary care. And we want all providers in primary care to feel comfortable prescribing to pregnant women, but we also want OBGYNs to become X-waivered. Now that it is, basically the click of a button to become X-waivered and to feel comfortable. Next slide, please. Speaking of, for all of our physicians and all of our residents, now that they have eliminated the 8-hour requirement to become buprenorphine waivered, I just quickly create like 5 steps, and most of these steps involve clicking with the mouse. You can prescribe to up to 30 patients without the formal training requirements. And literally you just have to put in your DEA, state medical license, and you will get your X-waiver. So making sure, having your X-waiver should be like having your DEA, which it is, it's tied to your DEA. So everyone should just have it because it's should be part of just being licensed. Next slide. All right. Take a yoga stretch here and switch quickly to sexual and reproductive health. Next slide, please. All right, so this is some work we've done on sexual and reproductive health. I'm gonna do a shout out to the Healthy People 2030 here to increase the proportion of women at risk of unintended pregnancy who use effective contraception and reduce the proportion of pregnancies conceived within a short interpregnancy interval. So that is typically defined by less than 18 months between pregnancies. And we know that the prevalence of unintended pregnancy among women with opioid and other substance use disorder is typically higher than the prevalence in the general population. And so a lot of our work has been focused on the postpartum period as really a unique opportunity to reduce reproductive health disparities because individuals have just had a child, and it's an opportunity to provide some education and counseling about sexual and reproductive health. There are barriers to the traditional means of providing, especially contraception. So the traditional 6 weeks postpartum visit is fading away for a variety of reasons, but less than half of women who have substance use disorders typically attend that follow-up postpartum visit for a variety of reasons that have been published, but it just cannot be relied on as the primary way to provide contraceptive and sexual reproductive health services. So I just wanted to talk to you guys briefly about some of the inpatient and immediate postpartum work that we've done thus far. Next slide, please. So this is some secondary data analysis work that we did with Pennsylvania Medicaid with my research and Dr. Miriam Jarlinski. So we looked at the fills for postpartum contraception after in the 60 days after delivery in women who had opioid use disorder. And we saw that 75% of women had no method observed, so no pharmacy fills. That excludes condoms and non-pharmacy-based methods, but 75% had nothing in the claims data. And about 18% had what we would call an effective method or a user-dependent method. And about 7% had a highly effective method. And most of that highly effective method was female sterilization. in comparison to less than 2% of women used a LARC. And those rates are lower than other Medicaid insured populations. Next slide, please. So this slide was interesting and important. So this looks at, this is a Kaplan-Meier survival curve. So this was looking at the time to next pregnancy by method choice after delivery. So the important thing about this slide is the red and the blue lines and how they are completely overlapping. So the blue line is no method in claims data, so nothing filled by pharmacy. And the red line is an effective method or a user-dependent method. And so there is absolutely no difference in the time to the next pregnancy between an effective method and no method observed. The green line is a LARC method, and then the kind of reference line, the brown line, is sterilization. So just showing that clearly the choice to have another pregnancy is completely within the individual. But if there is a desire not to have another pregnancy, there's really no difference between effective method choices and no choice at all. Next slide, please. So we wanted to understand a little bit more of why the utilization rates were low, potentially why the utilization rates were low, and to kind of step back a little bit and to look at the clinical pathways. So going back to the health services approach. So this is a single site evaluation. We looked at our data at the University of Pittsburgh and looked at documentation in the medical record of women who said in the medical record that they wanted to use a LARC. And so on the left-hand side there, 35% of women in the had medical record documentation that they wanted to use a LARC. But the problem is only half of those individuals attended a postpartum visit. And of those women who attended a postpartum visit, 40% got a LARC. So clearly they could have changed their mind, which is totally fine. But there's just kind of multiple steps and potential lapses in being able to deliver their method of choice or access related barriers that may prevent women from getting the method that they really desired. Next slide, please. So really, we have been working on increasing access to immediate postpartum contraception. And I wanted to share just a little bit of data from a observational clinical trial that we did among about 200 pregnant women with opioid use disorder. So basically what we did, this is before we really had started immediate postpartum IUD or kind of post-placental IUD insertion and had widely adopted immediate postpartum contraception in our hospital. So we had a few women get it through the Ryan White LARC program, but other than that, there was not a lot of immediate postpartum LARC options. So essentially what we did is we came to women and we talked to them about all contraceptive options, but if they wanted a long-acting method, we offered them Nexplanon before they went home. And there's a variety of reasons Nexplanon is attractive. You don't need to an exam table, a gynae exam table. It just is placed in the arm. It can be easily done in the postpartum units and is highly effective. Next slide, please. So next click, please. So again, it was observational. We just asked, we gave comprehensive contraceptive counseling and we offered it to women. There was no randomization. There was no paid incentive, nothing. We just offered it up. And we found that about 96 out of 194 women chose an immediate postpartum implant. So that's about 50% of women chose to get one inserted prior to going home. And that's just the implant. That's not even an IUD. Next slide, please. And next click, please. And this is continuation rate. So of those 96 women who received an implant in the immediate postpartum period, 80% of those women continued to use that implant at 12 months after delivery. So our continuation rates were extremely high and are consistent with continuation rates among other populations. Next slide, please. So repeat pregnancies. So we looked at, and this was within 1 year, even though historically kind of the short interpregnancy interval is 18 months. So in 1 year, we had 19 pregnancies among the 194 individuals. 17 of those pregnancies were in women who did not have an immediate postpartum implant. And 2 were in the implant group, but of course, those were in women who had the implant removed. They just remained in their group assignment, even though the implant was removed. So we had a significantly higher rate of close interpregnancy intervals among women who did not choose a highly effective method. And of the 17 individuals who had a pregnancy within the 12 months, 11 of those 17 pregnancies were unintended. Next slide, please. So this was just provisional exploratory, but I thought it was interesting. These are factors with, like, were there particular women who chose to choose an implant? And we found a decreased odds of choosing an implant if women were married, and an increased odds of choosing an implant with co-occurring substance use. So women who used alcohol, stimulants such as cocaine, and then less likely to choose an implant if they were stably engaged in treatment prior to pregnancy and during pregnancy, and also less likely to receive an implant if they were happy about their current pregnancy. So women who tended to be more unstable in their recovery or had co-occurring substance use were a little bit more likely to choose an implant, and women who were happy about their pregnancy had more social factors that were more stable for them, were less likely to choose an implant. Next slide, please. All right, I'm just going to have a couple of slides about hepatitis C because we do a lot of work on this too, and I just wanted to mention it's super important too. We looked at screening rates for hepatitis C in women who obviously have a risk factor, which is substance use, and in our hospital system, only 77% of women were screened, and that's just with the hepatitis C antibody. So we saw room for improvement there. And then among women who were screened with the antibody, or who were screened with OUD, 60% were antibody positive. Now, clearly, what we're looking for is women who have chronic infection or have a viral load. And I think from a provider perspective, a big issue was among the hepatitis C antibody positive patients, only 25% of those patients received a viral load to evaluate for chronic infection. So, and then if you look at the number of women who received hep C treatment after delivery, after they were identified prenatally, less than 2% received treatment after delivery. So this is kind of about a care cascade related to hepatitis. And it could also occur for HIV, although the prevalence of hepatitis is much higher. This involved a lot of provider education about the importance of screening. And then when somebody has a positive antibody status, the need to evaluate for chronic infection. So this data was before kind of the rise of universal screening recommendations for hepatitis, which have emerged literally in the last 12 months, which have been very exciting. And I'll get to that in a couple slides. Next slide, please. And I just want to point out quickly here, this slide's a little bit more difficult to read, but there are additional, so there's the downstream cascade of care for pregnant individuals, and then there's the cascade of care for infants who may have had hepatitis C exposure during pregnancy. So this was a paper looking at the children of women who had hepatitis C in pregnancy. And we saw that we looked at infants who had records, well-child records, meaning we knew these infants were receiving care in our hospital system. So therefore, they should theoretically be eligible to receive evaluation for hepatitis C because their mom was hepatitis C positive during pregnancy. And we found that, next click please, that only 30% of those infants were screened for hepatitis C, possibly missing some exposure and infection in babies. Next click, please. So there's the maternal cascade of care, and then that leads to the infant cascade of identification of pediatric infection. So we have now transitioned wonderfully to universal hep C screening in pregnancy, and that's now been finally recommended by all major professional organizations. So hopefully that will continue to close the gap, the screening gap. And now in our system, if you order new obstetric labs for like a new patient who's entering prenatal care, a best practice alert pops up if you don't order the hepatitis C screen. And then to kind of resolve this issue between antibody and RNA and getting providers to understand whether or not somebody actually has chronic infection, the need is to order the antibody that has an automatic reflex to the hep C RNA, so that providers aren't ordering two tests to eliminate that gap in care. And then clearly, just like not everybody needs to have a consult service, not everybody needs to have a perinatal hep C clinic, but we do have a reproductive infectious disease specialist here who, because of the prevalence substance use in our particular patient population and hepatitis C, we now have a Hep C clinic that's dedicated to pregnant and parenting women to help engage them in treatment. Because again, that additional link to hepatology and those additional steps that were necessary to get treatment were often highly burdensome for patients, and they were unable to engage. So we wanted to make our own treatment program that's specialized in this particular population. Next slide, please. All right, I think I'm going to transition briefly to stigma and COVID-19. These are just some brief discussions, and I mentioned them as emerging topics because I think we think about them as kind of issues, but we need to think about them. We need clinical pathways to address them, just like the clinical pathways I've mentioned for all of these kind of co-occurring disorders. They're just as important, and they're just as much of a problem in our health systems as misscreening, missed opportunities for access. And so I mentioned them as emerging in the sense that we need to really push the envelope of what is the clinical pathway for stigma? How are we going about educating our providers and our patients about what substance use is and how we can effectively treat it? So it needs to be treated the same way. So anyway, stigma is super, super real. I see it on a daily basis. I'm looking forward to the day where I don't see it on a daily basis, but it happens all of the time. And it's really about devaluing or excluding a person based on a real or frankly perceived difference. Next slide, please. So words matter, absolutely. These are just some examples of stigmatizing language that is used in alternatives. I think it's always important when bringing up words that are harmful is to provide an alternative so that providers know how to document, know how to communicate, and have an alternative approach to language. Next slide, please. And images matter. So this stuff drives me crazy too, because the whole needle issue is absurd. So we got to stop putting up pictures of needles. And so every time, if you have the opportunity to talk to somebody from the press, or I always say, please be thoughtful. I mean, all babies cry. So, putting up a baby crying is just totally not necessary. So anyway, images matter, words matter, it all matters. Next slide, please. So we surveyed our providers to kind of get at this issue. And this was physicians, nurses, social workers, and APPs. And we basically had all these statements. This is from a validated scale with these statements. And we asked them whether they agreed with these statements or disagree with these statements. And, agreements with those statements would indicate a level of stigma or misunderstanding, and then disagreement with no stigma. And basically came up with a stigma scale based on the number of the number of responses to these statements. Next slide, please. And, so basically the more stigmatizing responses that were answered by an individual on the survey, the higher their stigma scale. So the higher the number, the worse it got. And then we did stratify by type of provider to look for specific differences in provider type. And we had a great group of 0, but we did see, 1s, 2s, and some 3s there, which were a little different by provider type. And then it really fell off after 3, but it just was an objective quantification of, it exists across all provider types. And then that, like I said, we need to come up with clinical algorithms and process flows that incorporate education and a basic discussion about basic values and preferences of patients. Next slide, please. So anyway, I think you guys are aware of this, but it matters, and this should be one of our emphasis. Next slide, please. Last thing I'm going to mention is briefly COVID-19, because it's hard not to talk about COVID-19. And we are now almost, I think, going to reach 100,000 overdoses this year, or in the last 12 months. But this is this is CDC data actually from December of last year, which again needs to be updated because it's now climbing. But anyway, we've seen a rise. I think if you clinically care for individuals with substance use disorders, you've seen this, and then it's definitely bore out in the data that things have gotten worse during the pandemic for a variety of reasons. Next slide, please. And what I really want to emphasize is not really that, but that COVID-19 is bad among all patients, but a lot of patients with substance use disorders have a lot of co-occurring disorders that really increases their mortality from COVID-19. And I think helps bring to the table that there's a lot of comorbidities, a lot of co-occurring factors that are associated with substance use that really increase a predisposition for adverse health outcomes. We see this in severe maternal mortality. We see this in pregnancy-associated mortality, but we've seen this in COVID-19. And I think that's what I wanted to bring up is these other co-occurring disorders, just bringing to the table up the case mix of these patients sometimes can be incredibly complex and lead to really high rates of morbidity. Next slide, please. And this is just, again, as a reminder of polysubstance use, which I think adds to this kind of, it's not about opiate use, it's about a lot of co-occurring substance use, especially tobacco use, and thinking about chronic lung disease and predisposition for morbidity from COVID-19, the co-occurring stimulus and the co-occurring tobacco use and lung disease is a significant issue. Next slide, please. So we looked at differences in COVID-19 screening, diagnosis, and hospitalization rates in women with and without a substance use disorder diagnosis. So we found that screening rates were lower in women who, or individuals who had a substance use diagnosis. But the COVID-19 diagnosis rates were higher. So you have lower screening rates, but you have higher rates of diagnosis. But I think the real concerning line is that second line in that second red box is COVID-19 related hospitalizations were significantly higher among pregnant women who had a substance use diagnosis in comparison to women who did not. So, you know, the co-occurring factors, the associated comorbidities, increasing an individual's position for morbidity is significant. And I think addressing those co-occurring factors is something that COVID-19 has really, I think, brought to light. All right, that was a lot of information, but I loved talking about different ways to think about things, and clearly they are just kind of our particular slant on things, and super awesome and excited to hear feedback. But this is like my favorite quote, so I always end with it. From Dr. Winnicott, there's no such thing as a baby. If you set out to describe a baby, you will find that you are describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship. So I think, you know, we all need to remember that we're in the business of families and creating a family unit, and we're not in the business of moms or pregnant persons or babies or anybody. We're really interested in the entire composite social structure. So it's always important to remember. Thanks so much.
Great, thank you so much, Dr. Krans. That was excellent. We have time for just a couple questions as we are a bit behind. So I'm just going to select a few that have come up in the chat. The first was there an association for inadequate or poor prenatal care and positive UDS?
Right, because that is used often as a proxy for getting a urine drug screen. I am unaware of that, and I don't think was in that study. I need to look at that again. That was historically one of our, that particular one drives me crazy, and is used often, limited. We used to use less than 4 visits, but we eliminated that again. But that empirical evidence, I want to find that, but I haven't been able to, but that's used often. Great question.
Another question, were there legal or policy barriers to getting providers in the ED waivered? If so, what were they and how did you address them?
Yeah, so again, the waiver is really for that outpatient dispensing process. So you can dispense, so there's the 72-hour rule. I don't know if people are familiar with that, for ED providers to be able to administer buprenorphine in the ED to close that treatment gap. But to actually so the administered of the medication does not in the ED does not require a waiver, and there is no problem with that. It's I'm going to hand you a bottle of medication, then you need the X waiver. But then they have a medical license and DEA just like any other provider. So getting that waiver is not a problem. And now, like I said, without the 8-hour training, I mean, you just have to go to the website and click and sign up. Now there is, because everybody is doing that, the last I heard, I think there's like a 45 day lag between applying and actually getting the waiver assigned to your DEA. So you cannot start prescribing until that gets tacked on to your DEA. So go ahead and sign up, because it may be a couple of weeks, but that should not be a problem by provider type, if that's helpful.
Great. And then last question here. Do you equate stigma with non-trauma informed approach? And is there any research that looks at improvement in stigma with trauma informed training?
That's a great question. Yeah, I think is that the implied assumption that because the rate and prevalence of trauma is so high in certain patient populations, taking a non-trauma informed approach is stigmatizing. I think I'm just trying to reword that a little bit. Yeah, I think everyone should be approached with a trauma-informed approach. I mean, everyone should be approached in that manner. And so I think, right, I think stigma and bias is a larger curriculum, right? It's not just defining that a substance use disorder is a medical condition. It's about understanding a patient's experience and being able to have a lens that understands where patients are coming from, which includes a trauma-informed approach or a trauma-appropriate approach. So yeah, absolutely. I would agree with that, Sarah.
All right. Well, thank you so much. I think there are additional questions in the chat. What Cassie can do is probably cut and paste them and perhaps even send them to you, if possible, by email, so that we can make sure that we address these questions. But we really do appreciate your time and expertise, Dr. Krans. Thank you so much.
Anytime. And happy to reach out and discuss things at any time. Thanks so much. We really enjoyed it.
Great. Now we're going to change up our schedule just a bit, just so that we can get a little break and a little stretching in before we continue with the rest of the forum. So we're going to shorten our break to down about 5 minutes. So it is now 11:33. So let's meet back here at 11:38, and then we will continue with our third keynote of the day.